Welcome back to Beyond the Stethoscope, the podcast for general practitioners. For this deep dive, we're really getting into a cornerstone of general practice, and it's a critical area for our GP registrars prepping for those fellowship exams. Hypertension.
Absolutely. Hypertension is, well, it's just such a prevalent issue in our Australian communities, isn't it? It's the single most common reason people end up on long-term drug therapy.
Mm.
And, we all know it can be a silent contributor to pretty significant morbidity and mortality.
Mm-hmm.
And just to really underline its impact, almost 6%. Think about that, 6% of the total disease burden here in Australia is actually attributable to hypertension.
Wow, that's a huge number.
It's massive.
Yeah.
Huge number of lives, health outcomes affected.
It is, and that's exactly why we're dedicating this time to it today. Our goal really is to provide a really comprehensive understanding of hypertension for you. We'll be looking at everything from the basic definitions and classifications right through the really essential bits like risk stratification, how to detect it properly, thorough evaluation, and of course the practical side management, both lifestyle stuff and the pharmacological approaches.
Yes. And importantly, everything we talk about will be grounded in the current evidence-based guidelines, the ones relevant to our practice here in Australia.
Crucial.
So to guide us, we'll kick off by clarifying those definitions and the various ways we classify hypertension. Then we'll move into that vital area of risk stratification. We'll focus on how you can effectively calculate a patient's overall cardiovascular risk because, honestly, it's so much more than just that blood pressure number itself. We'll also touch on secondary hypertension, those cases where there's a specific identifiable underlying cause. After that, we'll cover the recommended techniques for actually detecting hypertension accurately. Then dive into the comprehensive evaluation process. And finally, we'll spend a good chunk of time on management strategies, drug-based, and touch on some important points for specific groups, like kids and the elderly.
And a really key insight, something we want you to take away quite early on, is this: effectively stratifying a patient's risk. It involves much, much more than just noting down their blood pressure readings. This is where it gets really practical for us GPs. It's about piecing together that whole clinical picture, considering all the absolute cardiovascular risk factors, being mindful of any other associated clinical conditions that can significantly, influence prognosis and management.
Exactly. So let's start by laying that groundwork. Definitions and classification. As you'd find detailed in resources like, say, the Australian National Heart Foundation guidelines, we categorize blood pressure based on systolic and diastolic readings. So, optimal blood pressure that's defined as below 120 systolic and below 80 diastolic. Nice and low.
Okay.
Normal is in the range of 120 to 129 systolic and 80 to 84 diastolic. Then we get into this category called high normal. That's a 130 to 139 systolic and 85 to 89 diastolic.
And it's worth flagging that high normal group, isn't it? They're already at a somewhat increased risk compared to those with optimal readings.
Precisely. It's not quite hypertension, but it's certainly not optimal either. It's a flag.
Okay, so let's unpack those figures further into the clinical grades of hypertension we actually diagnose and manage. Grade 1 hypertension, often called mild, that's the range of 140 to 159 systolic and or 90 to 99 diastolic. Grade 2, or moderate hypertension, is when the readings are 160 to 139 systolic and or 100 to 109 diastolic. And then grade 3, which we classify as severe hypertension, is characterized by readings of 180 systolic or higher and or 110 diastolic or higher.
And recognizing these grades really helps us gauge that initial severity, doesn't it? And it starts guiding our management approach right from the get-go.
Absolutely.
We also need to be particularly aware of something called isolated systolic hypertension. This is defined as a systolic blood pressure of 140 mmHg or greater, but with a diastolic blood pressure that's actually below 90 mmHg.
Right. You see this a lot, particularly in older patients.
Very common, yeah. Often due to that age-related arterial stiffening. But the key point is it's not benign. Just because the diastolic is okay doesn't mean we ignore it. It carries a significant cardiovascular risk and absolutely requires proper assessment and management.
Good point. And when we think about the why behind the high blood pressure, the underlying causes, we broadly split it into essential and secondary, right?
That's the main division, yes. Essential hypertension makes up the vast majority of cases, maybe 90 to 95%. This is where we see that sustained high blood pressure. But we can't actually pinpoint a specific underlying kidney issue or an adrenal problem or some other correctable medical condition.
The cause isn't obvious.
Exactly. It's often multifactorial, a mix of genetic predisposition, environmental factors, lifestyle. It all adds up.
Okay, so that's essential. What about the other 5–10%? Secondary hypertension.
Right, so secondary hypertension accounts for that smaller percentage, roughly 5 to 10%. And in these situations, the high blood pressure is a direct result of an identifiable underlying cause.
Something specific we can potentially treat.
Precisely. And this could involve a whole range of conditions. Various kidney diseases are common culprits, like renal artery stenosis or chronic kidney disease. Endocrine disorders, too, think primary aldosteronism, Cushing syndrome, pheochromocytoma. Even structural issues like coarctation of the aorta, certain medications like NSAIDs or the oral contraceptive pill, and even conditions like obstructive sleep apnea.
Which is increasingly recognized.
Absolutely. So recognizing that possibility of secondary hypertension is crucial because sometimes treating that underlying cause can actually resolve or significantly improve the high blood pressure itself.
Worth looking for. We should also briefly touch on malignant hypertension. Less common, thankfully.
Yes, much rarer but very serious. It's characterized by severely elevated diastolic pressure, typically over 120 millimilli Hg, and crucially, evidence of acute end organ damage. Specifically, we look for things like exudative vasculopathy in the retina or the kidneys. These patients can deteriorate quickly and need urgent medical attention.
Definitely an emergency. And what about refractory hypertension?
Refractory hypertension is basically blood pressure that stays stubbornly above the target level. Usually we think 4 to 20/90, even though the patient is on maximally tolerated doses of at least 3 different antihypertensive medications, and one of those should ideally be a diuretic.
So despite doing seemingly everything right pharmacologically,
Yeah. And that situation often warrants digging deeper, really looking again for secondary causes, or perhaps addressing adherence issues, or even considering things like white coat effect more formally.
okay, that sets the scene nicely with definitions. Let's move to that really critical area, risk stratification.
Yes, this is vital. For GPs, for registrars especially, understand that this is key. Our decisions about managing hypertension shouldn't just hang on the BP reading alone. As guidelines from bodies like the Heart Foundation emphasize, we absolutely must take into account the patient's overall cardiovascular risk profile.
The bigger picture.
Exactly. Considering other significant risk factors, things like age, whether they have diabetes, their smoking status, lipid levels, it all matters.
That makes perfect sense because, like we hinted earlier, the actual benefit a patient gets from treatment is often less pronounced if their overall baseline risk of having a cardiovascular event is already quite low, right?
Precisely. Treating someone with mild hypertension and zero other risk factors has a different NNP number needed to treat compared to someone with the same BP but who also smokes, has diabetes, and is older. The benefit is much clearer in the second case.
So how do we practically go about stratifying this risk in our day-to-day practice?
Well, we assess the patient's blood pressure level, but we put it into context with several other key factors. These tend to fall into categories. First, there are the absolute cardiovascular risk factors.
Okay, like
Things like age, generally being male over 55 or female over 65, puts you in a higher category. Current cigarette smoking, obviously, having a diagnosis of diabetes mellitus, or having dyslipidemia, which usually has specific thresholds defined like total cholesterol, maybe above 6.5 millimole, LDL above 4.0, or low HDL less than 1.0 in men, less than 1.2 in women.
standard lipid targets. Okay.
We also look at family history, specifically a history of premature cardiovascular disease. That means a first-degree relative, like a parent or sibling who had a heart attack or stroke before age 55 if male or before 65 if female.
That premature aspect is important.
Very. And finally, abdominal obesity, often defined by waist circumference, say 102 centimeters or more in men, 88 centimeters or more in women.
Right. So those are the sort of established traditional risk factors we often screen for. What about other clinical conditions or, signs of existing damage that we need to factor in?
Good question. We also need to actively consider what are called associated clinical conditions. This includes things like a prior history of cerebrovascular disease, an ischemic stroke, a brain hemorrhage, even a TIA. A history of heart disease is critical. Previous MI, angina, maybe they've had coronary revascularization like stents or bypass surgery or a diagnosis of heart failure.
Makes sense.
Kidney disease is another big one. Diabetic nephropathy, any evidence of kidney impairment like a reduced eGFR, significant proteinuria, say over 300 milligrams in 24 hours, and also peripheral vascular disease.
Okay. And what about evidence of damage specifically caused by the hypertension itself? Target organ damage.
Yes, that's the next layer. Evidence of target organ damage. This can manifest in several ways. Advanced hypertensive retinopathy, seeing hemorrhages, exudates, or even papilledema on fundoscopy. Left ventricular hypertrophy, which we might pick up on an ECG or see more clearly on an echocardiogram. microalbuminuria, or more significant proteinuria, and/or an estimated GFR below 60 milliliter a minute indicating kidney damage.
Right.
Ultrasound or angiographic evidence of atherosclerotic disease, like finding carotid plaques. And as mentioned, hypertensive retinopathy of grade 2 or more on fundoscopy is itself considered target organ damage.
That's a pretty comprehensive list of factors that really add up to that overall cardiovascular risk. And I notice guidelines often mention other, maybe less direct aspects that can still influence a patient's prognosis.
They do. These often include things like excessive alcohol intake, which has a direct effect on BP too. The use of certain complementary or alternative medicines, some can interact badly, like those containing tyramine with certain older antidepressants, for example. A predominantly sedentary lifestyle, of course. And belonging to a socioeconomic or ethnic group that we know from population data is at higher risk for cardiovascular disease. All these elements paint a fuller picture of that individual's risk.
Okay, so with all of these different pieces of information, the BP level, the risk factors, the associated conditions, target organ damage, other factors, how do we practically synthesize all that in a busy GP clinic to actually assign a risk level? It sounds like a lot to juggle.
It can seem like it, but thankfully many guidelines provide a framework to help categorize this total cardiovascular risk. For instance, the Australian guidelines often use a system classifying patients into low risk, which is less than a 10% estimated risk of having a cardiovascular event in the next 5 years. Moderate risk, where the 5-year risk is between 10 and 15%. High risks, where that 5-year risk is 15 to 20%. And for these individuals, we'd generally be thinking about starting treatment fairly promptly.
Right, the threshold gets lower.
Exactly. And then there's very high risk, where the 5-year risk is over 20%.
And how do we actually calculate or estimate these percentages during a consult? It feels like mental gymnastics sometimes.
Yeah, doing it purely from memory with all factors is tough. Fortunately, we have validated cardiovascular risk estimation tools available to help us. A widely used one here in Australia and New Zealand is based on the Framingham study, often presented as risk charts or online calculators. The Heart Foundation website is a great resource for these.
Ah, the calculators, yes.
They take into account many of the risk factors we've discussed: age, sex, smoking, BP, cholesterol, diabetes, and give you that estimated 5-year risk percentage. It's also worth looking at the relevant chapters in clinical guidelines, like Murtaugh's or others, which explain risk assessment in detail.
And then the crucial step is communicating this.
Absolutely crucial. Have a clear, collaborative discussion with your patient. Explain their estimated cardiovascular risk, using the calculator's output in understandable terms. Talk about their blood pressure level alongside that risk. This shared understanding is the foundation for making informed decisions together about lifestyle changes and the potential pros and cons of starting medication.
Excellent. Now let's shift focus a bit to secondary hypertension. We mentioned it earlier. What are some of the key clinical clues or situations that should really make us pause and think, hang on, could this high BP be a symptom of something else?
Good question. There are several red flags or suggestive features that should definitely raise our index of suspicion for secondary hypertension. When is the onset of hypertension at an unusually young age, say under 40, especially if there isn't a strong family history of early onset essential hypertension?
Okay, young onset.
Another is blood pressure that's just really poorly responsive to treatment. You've got them on 2, 3 appropriate drugs at good doses, and the BP is still way off target. That's refractory hypertension, which we mentioned, and it warrants investigation.
Makes sense.
The presence of accelerated or malignant hypertension, that severe end of the spectrum, that strongly suggests an underlying cause too. And then there are specific physical examination findings, like hearing an abdominal systolic brute on auscultation. That swooshing sound might indicate turbulent flow due to renal artery stenosis.
Right.
Urine abnormalities are important clues too. Significant proteinuria, hematuria, or finding casts in the urine sediment can point towards underlying kidney diseases like glomerulonephritis. And finding bilateral, palpable kidney masses could suggest polycystic kidney disease, although that's less common.
So those are some key findings on exam. What about other things in the history or the rest of the examination?
Well, a history of claudication, that leg pain on exertion, especially if combined with finding diminished or delayed femoral pulses compared to the radial pulses in the arms, that should make you think about coarctation of the aorta. That narrowing can cause upper body hypertension.
Okay.
Symptoms like progressive nocturia, getting up multiple times at night to urinate, and maybe unexplained muscle weakness, especially if their potassium level is low, should prompt you to think about primary aldosteronism, a hormonal cause.
Aldosterone, right.
We should also be really alert to that classic triad of obesity, loud snoring, and excessive daytime sleepiness. That's highly suggestive of obstructive sleep apnea, which is actually a pretty common but often missed cause of secondary hypertension.
Definitely need to ask about sleep.
Absolutely. And it's crucial always to take a thorough medication and substance use history. Various recreational drugs, stimulants, diet pills, even prescribed meds like NSAIDs, steroids, OCPs, some antidepressants, and even things like energy drinks can push blood pressure up.
Good reminder about medications.
And finally, those classic episodes of paroxysmal, sudden onset hypertension may be accompanied by headache, pallor, looking pale, sweating, palpitations. That should raise suspicion for a pheochromocytoma, that rare adrenal tumor.
Okay, quite a range of clues there. And what are the most common underlying medical conditions we actually see causing secondary hypertension in practice?
By far, the most frequent culprits are various forms of kidney disease. This includes renovascular disease, primarily renal artery stenosis, but also chronic glomerulonephritis, reflux nephropathy, diabetic nephropathy, essentially problems with the kidney parenchyma or its blood supply.
So kidney issues are top of the list.
Definitely. Often the physical exam might not give you specific signs for these, but the urinalysis, as we mentioned, can be very informative looking for protein, blood, abnormal sediment. We should also always consider underlying obstructive sleep apnea, just because it is relatively common and treatable. And as we keep emphasizing, that detailed medication history is essential to rule out iatrogenic causes hypertension caused by other treatments.
You mentioned some specific physical exam findings earlier that might point more directly to particular causes. Could you just recap those key ones again?
Sure. Besides the abdominal broods suggesting renal artery stenosis or maybe a large AAA, less common but important findings include those palpable flank masses, which could be polycystic kidneys. The finding of delayed or absent femoral pulses compared to radial pulses, that radiofemoral delay is a key sign for possible coarctation.
Right.
In Cushing syndrome, you might see that characteristic central obesity with purplish striae on the abdomen, maybe a buffalo hump. And for pheochromocytoma, remember that classic triad during an episode: tachycardia, sweating, pallor. Of course, many endocrine causes are complex and ultimately rely on specific biochemical testing for diagnosis, not just the physical exam.
And if we do strongly suspect renal artery stenosis based on the clinical picture, say an older patient with resistant hypertension and maybe a brute, what's the typical first investigative step?
Well, atherosclerotic renal artery stenosis is the most common cause, especially in older folks with other signs of vascular disease. In younger patients, especially women, you also need to think about fibromuscular dysplasia. Generally, the initial investigation of choice is a Doppler ultrasound of the renal arteries. It's non-invasive and pretty sensitive and specific for detecting stenosis by looking at blood flow velocities and patterns in those arteries. Okay, Doppler ultrasound, good starting point. Let's move on now to the absolute fundamentals of actually detecting hypertension. Seems basic, but getting it right is crucial. You're absolutely right. It's a cornerstone, isn't it? And the key thing to remember is hypertension can only be detected if we actually measure the patient's blood pressure. Sounds obvious, but we need to be proactive.
Opportunistic screening.
Exactly. Take opportunities. For people we know are at higher risk, maybe more frequent checks every 6 to 12 weeks could be appropriate in some cases. For those at lower risk, an annual or biannual check, say every 6 to 12 months, is usually reasonable.
And critically, making the diagnosis of hypertension isn't something we should rush into based on just one reading, is it?
No, definitely not. That's a really important point for practice. An initial high reading should always be confirmed with repeat measurements. We need measurements taken on at least 2 subsequent separate occasions, ideally within maybe a 3-month period.
Looking for consistency.
Yes, we're looking for a consistently elevated average level, say 90 mmHg Hg or higher diastolic, or 140 mmHg Hg or higher systolic across these multiple visits before we confidently label someone with hypertension. This helps us avoid misdiagnosing people who just had a one-off high reading due to stress, the white coat effect, or something else transient, and that avoids unnecessary long-term treatment.
Okay, so multiple readings over time. What about the technique itself? What are the key procedural bits we need to get right for accurate measurement in the clinic?
Accuracy here is paramount because our decisions hinge on these numbers. First, the device. Whether it's a traditional manual sphygmomanometer or an automated electronic one, make sure it's validated, regularly calibrated, and the cuff size is right for the patient's arm.
Cuff size is critical.
Absolutely. Too small a cuff gives a falsely high reading. Too large gives a falsely low one. Standard adult cuff is about 12, 13 centimeters wide, 35 centimeters long, but you need larger ones for bigger arms. Before measuring, let the patient sit quietly for at least 5 minutes. Feet flat on the floor, back supported, arms supported at heart level. No talking.
Quiet rest period.
Essential. Then take at least 2 readings spaced about 60 seconds apart. As mentioned, the arms should be roughly at heart level. Guides often show a picture of this, like FI 77.1 in Murtaugh. If using a manual device, deflate the cuff slowly, about 2 mmHg per second, so you can accurately hear the Korotskov sounds.
Low deflation.
Yes. And it's also good practice, especially in older patients, diabetics, or anyone reporting dizziness on standing, to measure the BP standing up at least once to check for postural hypotension.
Okay, good tip. And how should we record and interpret the readings we get during a visit?
For each measurement session, you should average those 2 or more readings you took. Remember to wait at least 30 seconds between them. If the first 2 readings are quite different, say by more than 6 mmHg systolic or 4 mmHg diastolic, it's wise to take 1 or 2 more readings and then average all of them.
Get a more stable average.
Exactly. When recording, always note both systolic and diastolic values. For diastolic with a manual cuff, we record phase 5 Korotskov sound, the point where the sound disappears completely.
Disappearance phase 5. Got it. What about checking heart rate and pulse at the same time? Should that be routine?
Yes, absolutely. Good practice to record both the heart rate and note the rhythm while you're measuring BP. A consistently high heart rate might indicate anxiety or other factors are pushing the BP up. And if you feel an irregular pulse, that could suggest something like atrial fibrillation, which can actually make some automated BP devices less accurate and obviously has major implications for stroke risk assessment itself.
Important point about AFib. Are there specific things patients should avoid doing just before their BP check in the clinic?
Yes, several things can temporarily bump up blood pressure, so it's helpful to advise patients. Clinic anxiety or white coat apprehension is real, so that 5-minute quiet rest period is key. They should avoid caffeine, coffee, tea, cola, energy drinks for at least 4 to 6 hours beforehand.
4 to 6 hours, okay.
And avoid smoking for at least 2 hours before, as nicotine constricts blood vessels. Also, generally best to avoid a heavy meal or strenuous exercise for about 30 minutes right before the measurement.
Okay, practical tips for patients. What's a sensible approach if we get a surprisingly high first reading in someone with no known history of hypertension?
If you get an unexpectedly high initial reading, the first step is simply have the patient sit quietly and rest for another 5 or 10 minutes, then repeat the measurements.
Let them settle down again.
Exactly. That white coat effect can be really significant for some people. If the repeat readings in the clinic are still elevated, then you need to arrange for further BP monitoring outside the clinic environment. This might involve getting them to use a validated home automated BP monitor, taking readings at different times of day over several days, or in some cases, arranging formal 24-hour ambulatory blood pressure monitoring, ABPM, which gives the most comprehensive picture.
Right. Out-of-office measurement is key sometimes. And what are the general guidelines for actually confirming the diagnosis and then the follow-up intervals?
So after that initial elevated reading, you need those repeated measurements to confirm it's sustained. You need to track the trends over time. Guidelines often have tables, like Cable 77.6 in Murtaugh, that suggest follow-up based on the initial BP level. For instance, if BP is normal, 20/80, recheck in maybe 2 years. If it's in that high normal or pre-hypertension range, 120, 139, 80, 89, recheck within a year and definitely give lifestyle advice. For grade 1, 140, 159, 90, 99, you want to confirm that within about 2 months, again with lifestyle advice. For grade 2, 160, 179, 100, 109, you need to evaluate or refer within about a month. And for grade 3, 180 or 110, evaluate or refer within a week, or potentially immediately if they're symptomatic or there's evidence of organ damage.
So the urgency increases with the level.
Absolutely.
Yeah.
And if you confirm the BP is consistently O180 systolic or O110 diastolic, and you've reasonably ruled out white coat effect, guidelines generally recommend starting drug treatment fairly promptly. For less severe but confirmed hypertension, you might watch and wait with repeated measurements over 3 to 6 months while they really focus on lifestyle changes before deciding on medication. Depends on the overall risk profile, too.
When is ambulatory 24-hour monitoring ABPM particularly useful?
ABPM is a fantastic tool in several specific situations. It's invaluable if someone has really variable office BP readings up one visit, down the next. Yeah. Or if there's a big difference between their clinic readings and the readings they get at home. Also, when you suspect resistant or refractory hypertension, the BP just isn't responding to treatment as you'd expect. It's the gold standard, really, for diagnosing true white coat hypertension,
Yeah.
as it shows if the BP is normal outside the clinic.
Right. Proves it's just in the clinic.
Yes. And it can also be helpful if you suspect sleep apnea, as the nighttime BP pattern can be revealing. Generally, if you've got 2 or more office readings consistently over 40/90, especially if the picture is unclear, thinking about ABPM is a good idea.
Can you just quickly clarify the difference between white coat hypertension and masked hypertension?
Sure. White coat hypertension is when the BP is high only in the clinic setting, but normal when measured at home or with ABPM. These folks generally have a lower immediate risk than those with sustained hypertension, but they might be more likely to develop sustained hypertension later on, so they still need monitoring.
Okay.
Masked hypertension is the opposite. The BP looks normal in the clinic, but it's actually elevated when measured at home or with ABPM. It is. And masked hypertension is thought to carry a worse prognosis than having consistently normal BP. We should suspect it if someone has signs of end organ damage like LVH on ECG, but their clinic BPs always seem fine.
Good to keep in mind. And we mustn't forget isolated systolic hypertension, especially in our older patients. Key things there.
Absolutely crucial not to dismiss it. Remember, systolic 140 but diastolic 90. Very common with age due to stiff arteries. It is not benign. It significantly increases cardiovascular risk. Detection is the same repeated office measures. Consider home or ABPM if needed. If lifestyle changes don't bring the systolic down enough, medication is usually warranted. The target might be slightly higher in older, frailer individuals, say aiming for 150 or 160 systolic, always balancing benefit against the risk of side effects like dizziness or falls.
Great summary. Okay, let's turn to the evaluation phase. Once we've confirmed the diagnosis, what are the main goals when we evaluate a patient with newly diagnosed or poorly controlled hypertension?
The evaluation really aims to achieve several key things. Firstly, we want to actively look for any potentially reversible underlying causes, that secondary hypertension piece.
Rule out the treatable causes.
Exactly. Secondly, we need to carefully assess for any existing target organ damage. Has the high BP already caused harm to the heart, brain, kidneys, eyes, or blood vessels? Thirdly, we must identify any other modifiable cardiovascular risk factors the patient has. Smoking, high cholesterol, diabetes, obesity, because we need to manage those two.
Holistic approach.
Yes. And finally, we need to be aware of any coexisting medical conditions, comorbidities, that might influence our choice of antihypertensive drugs or the overall management strategy. This comprehensive evaluation allows us to tailor the treatment plan specifically to that individual patient.
So, what are the key components of taking a really thorough medical history in someone with hypertension?
The history is absolutely essential. You need to ask about their hypertension journey. When was it diagnosed? How? What have the levels typically been? How long have they had it? Ask about symptoms that might suggest target organ damage, headaches, shortness of breath, chest pain, palpitations, leg swelling, ankle edema, changes in vision, any history of TIA or stroke symptoms.
Okay.
And specifically ask about symptoms suggesting secondary causes like those we discussed earlier, muscle weakness, palpitations, snoring, etc. Table 77.5 often lists these. Get a detailed history of previous antihypertensive treatments, what drugs, what doses, did they work, any side effects.
Yeah.
Very important.
Yeah, avoids repeating failures.
Exactly.
Yeah.
Then ask about other medical conditions and risk factors, heart disease, stroke, kidney disease, diabetes, high cholesterol, weight gain, obesity, smoking status, typical salt intake, alcohol consumption, physical activity levels, regular analgesic use, especially NSAIDs. A detailed family history is also important. Hypertension, premature heart disease or stroke, high cholesterol, diabetes, kidney disease in relatives.
Right.
And finally, that comprehensive medication history again. All prescriptions, over-the-counter meds, herbal remedies, supplements. Specifically ask about things known to raise BP, alcohol, OCPs, HRT, steroids, NSAIDs, COX-2 inhibitors, decongestants, sympathomimetics, appetite suppressants, certain antidepressants, MAOIs, SNRIs, stimulants, even things like natural licorice.
Licorice always surprises people. And alcohol, how much detail?
You need to quantify it reasonably well. Ask about average daily or weekly intake in standard drinks. More than 2 standard drinks a day is generally considered significant for BP.
Okay, comprehensive history. What about the key physical examination findings we should be looking for?
The physical exam should focus on 2 main things: looking for signs of target organ damage and looking for clues suggesting secondary hypertension. Clinical guides often have helpful diagrams, like FI 77.3. Fundoscopy is crucial, examining the back of the eye for hypertensive retinopathy. We grade the changes seen, FI 77.4 shows examples, from mild arteriolar narrowing, grade 1, up to papilledema, grade 4.
Eye exam is key.
Very. We should carefully palpate and compare pulses in the arms and legs. Check for radiofemoral delay, coarctation. Check for diminished peripheral pulses, PVD. Consider measuring BP in both arms initially, and maybe in a leg, looking for significant differences. Calculating the ankle brachial index, ABI, is a good screen for PVD.
Right.
Listen carefully over the abdomen for Brute's renal artery stenosis, or AAA. Perform a thorough cardiovascular exam. Listen to the heart for murmurs, extra sounds. Assess for signs of heart failure, like raised GVP or peripheral edema. Check for signs suggestive of endocrine causes, if suspected. Example, Cushingoid features.
Okay, so focused exam. What about baseline lab tests? What should we routinely order for a newly diagnosed hypertensive patient?
The standard baseline investigations are pretty well established. You'll want a fasting plasma glucose to screen for diabetes or impaired glucose tolerance. A fasting lipid profile, total cholesterol, HDL, LDL, triglycerides to assess for dyslipidemia.
Glucose lipids.
Serum creatinine with an estimated GFR, eGFR, to assess kidney function, and also a urine albumin to creatinine ratio, ACR, to check for microalbuminuria or proteinuria, early signs of kidney damage. Serum electrolytes, particularly sodium and potassium. Low potassium might hint at hyperaldosteronism. Serum uric acid, as thiazides, can raise it, and it's an independent cardiovascular risk factor.
Right.
A full blood count, looking at hemoglobin and hematocrit, and a urinalysis, dipstick, and microscopy, looking for blood, protein, glucose, casts, or other abnormalities suggesting kidney disease. Finally, a baseline electrocardiogram, ECG, is recommended to look for evidence of left ventricular hypertrophy, LVH, or any underlying arrhythmias or ischemic changes.
That's a solid baseline workup. Are there any other investigations we should consider in specific situations or if we suspect something more complex?
Yes, definitely. Depending on the clinical picture, other tests might be warranted. An echocardiogram gives much more detail about cardiac structure and function, especially LVH, than an ECG alone. Carotid or femoral artery ultrasound can assess for atherosclerotic plaques if you suspect significant vascular disease. If the fasting glucose is borderline or high, or there's a strong suspicion of diabetes, an HbA1c test gives a longer-term picture of glucose control.
Makes sense.
In cases of severe or resistant hypertension, or if specific clinical clues point towards a secondary cause, you'd consider more targeted investigations. This might include kidney imaging like a renal ultrasound, perhaps with Doppler studies if concerned about renal artery stenosis. If suspecting pheochromocytoma, you'd order 24-hour urinary catecholamines and medinephrines. And if primary aldosteronism is suspected, example, hypertension with hypokalemia, you'd measure plasma aldosterone and renin levels, often calculated as an aldosterone to renin ratio.
Okay. Tailored further investigations. Let's move into the crucial part now. Treatment. Once we've got the diagnosis confirmed and the evaluation done, what are the guiding principles for managing hypertension?
Right, the management phase. The absolute main goal is to improve the patient's long-term survival and their quality of life by reducing their risk of cardiovascular events like heart attack, stroke, heart failure, and kidney failure.
The ultimate outcome.
Exactly. This really requires a strong doctor-patient relationship built on trust and shared decision-making. Our general aim is usually to reduce BP levels to below 490 millimilli Hg, though, as we've said, the specific target might be lower in certain groups like people with diabetes or established kidney disease, always balancing the benefits against potential side effects and patient tolerability.
Individualized targets.
Yes. And we must conduct a thorough assessment of all their modifiable cardiovascular risk factors and address those concurrently: smoking, lipids, glucose, weight, etc. It's not just about the BP number. Critically, we have to instruct all patients, regardless of whether they need medication, on the benefits and specifics of non-pharmacological lifestyle strategies.
Lifestyle first or alongside meds?
Always. In patients with milder hypertension, say grade 1, and no target organ damage or high CV risk, it's often very reasonable to have a dedicated trial of intensive lifestyle changes first, maybe for 3-6 months, perhaps guided by home or ambulatory BP monitoring before jumping to medication.
Give lifestyle a chance.
Absolutely. But drug therapy is clearly indicated for those with persistently high readings despite lifestyle efforts, those who already have target organ damage, those at high overall CV risk, or those presenting with severe hypertension. When choosing a drug, we need to carefully weigh up the individual patient's characteristics, other health problems, the drug's potential side effects, how simple the dosing regimen is, and the cost.
Lots to consider.
Yes. We also need to be vigilant for drug-related problems like postural hypotension, especially in older adults. And generally, we should avoid lowering BP too quickly or aggressively. particularly if it's been high for a long time. Gradual reduction is usually safer. And finally, engaging the patient actively in their own care, addressing their concerns, exploring reasons for non-adherence. These are all vital for long-term success.
That patient engagement and education piece seems absolutely central. What are some key messages and strategies we should use when talking with patients about their hypertension?
It's incredibly important. Effective education starts with providing reassurance, but also clear, simple information about what hypertension is, why it matters even if they feel fine, and what the goals of treatment are.
Demystify it.
It's exactly. Make sure they understand the potential long-term consequences of untreated high BP heart attack, stroke, kidney failure, and the proven benefits of lowering it. We need to actively tackle common misconceptions. Things like, hypertension can be cured, so I can stop treatment later. Usually not true for essential HTN.
Oh,
Or, I don't need treatment if my BP is controlled now. Or, I don't need pills because I feel fine. Or, I can tell if my BP is high by how I feel. Mostly untrue. Or, I can stop my pills if I make lifestyle changes. Maybe, but needs careful monitoring.
busting those myths is key.
Absolutely. Emphasize that for most people with essential hypertension, it's a long-term condition requiring ongoing management, often including medication, even when the BP is well controlled.
Mm.
Practical tips for adherence are crucial. Talk about the best time of day to take pills consistently. Set clear therapeutic goals together. Use reminder systems if needed. Provide good quality written patient information leaflets. And at every follow-up, gently ask about missed doses. Review their overall CV risk factors again. Proactively ask about any side effects. Don't wait for them to volunteer it. Addressing side effects quickly and finding solutions is vital for keeping people on treatment.
Great advice. Now, let's talk specifically about those non-pharmacological or lifestyle management strategies. When are they appropriate as the main approach, and what specific measures should we be recommending?
Lifestyle measures are fundamental for everyone with high BP, or even high normal BP. If someone presents with newly diagnosed mild hypertension, say average diastolic BP between 90 and 100, and they have no target organ damage or high overall CV risk, a dedicated trial of non-pharmacological therapy for about 3 months without starting drugs is often a very reasonable first step.
Okay, a 3-month trial.
During this time, or even before, it's also crucial to review their current medications and stop or switch any that might be contributing to the high BP NSAIDs, corticosteroids, OCPs, HRT, etc., if possible.
Remove offending agents.
Exactly. Then, the key lifestyle modifications to recommend include weight reduction for anyone overweight or obese, calculate their BMI, discuss realistic goals. Aiming for a healthy waist circumference, 94 centimeter, 80 centimeter F for BMI, around 25 is ideal. Even modest weight loss helps.
Weight loss, okay.
Reducing excessive alcohol intake. The general advice is limit to no more than 1 to 2 standard drinks per day on average. Reducing dietary sodium intake. Aiming for less than 4 grams of sodium per day, which is about 1.5 teaspoons of salt. This means avoiding adding salt at the table or in cooking, and being really mindful of processed foods, takeaways, canned soups, sauces. They're often loaded with hidden salt.
Salt reduction is tough, but important.
Very. Encouraging increased physical activity. Regular aerobic exercise, like brisk walking, aiming for at least 150 to 300 minutes per week. For some, stress reduction techniques might be beneficial: relaxation therapy, meditation, mindfulness. Other dietary factors can help modestly. Adopting a diet rich in fruits, vegetables, whole grains, like the DAAH diet pattern, ensuring adequate potassium and calcium intake, limiting saturated and total fat, and advise avoiding natural licorice, the confectionery type, as it contains glyceric acid, which can raise BP.
Right.
And absolutely crucial, if they smoke, provide strong advice and support for smoking cessation. The benefits go way beyond BP control.
Smoking cessation is paramount.
And if you suspect obstructive sleep apnea, arranging assessment and treatment, like CPAP, can lead to a modest but helpful BP reduction too.
Okay, comprehensive lifestyle advice. When do we typically decide, okay, lifestyle isn't enough, it's time for medication?
Generally, the evidence shows the benefits of drug therapy clearly outweigh the risks for people whose diastolic BP stays persistently above 95 mmHg despite lifestyle efforts, especially if sustained over weeks or months. We also consider starting medication earlier in patients who already have evidence of target organ damage, those who are at high or very high overall cardiovascular risk based on our assessment, and obviously in individuals whose BP just isn't coming down sufficiently with non-drug measures alone.
Risk level plays a big role.
A huge role. When deciding which specific drug to start with, we need to consider the patient's overall health profile, Any comorbidities like diabetes, asthma, heart failure, kidney disease, the drug's side effect profile, how easy it is to take once daily is usually best for adherence, and the cost. Clinical guidelines often provide useful flowcharts like FIG 77.5 to help choose first-line options.
Coexisting conditions are key.
Yes, they can definitely guide choices or rule out certain classes. For example, beta blockers might be less ideal or even contraindicated in severe asthma or COPD, as a rough guide for when to start drugs based on risk. In patients with a calculated 5-year CV risk over 15%, high, very high, we generally treat if their BP is consistently above 140 systolic or 90 diastolic. For those with moderate risk, 10–15%, we also typically consider treatment at those same DP thresholds, 190. For individuals at lower risk, 10%, we might have a slightly higher threshold before starting meds, maybe 160 systolic or 100 diastolic, especially if there's no target organ damage.
Higher threshold for lower risk patients.
Generally, yes. But these are just guidelines. The decision always needs to be individualized, discussed with the patient, considering their preferences and the whole clinical picture. And treatment targets, table 77.7, also vary depending on the patient group.
Okay, so once we decide to start medication, what are the general principles for initiating and adjusting therapy?
The usual approach is to start with a single drug, typically at a low dose.
Hello.
Go slow. Exactly. Then you need to allow enough time for that dose to take full effect, which is usually around 4 to 6 weeks for most antihypertensives, before you reassess the BP response properly. If the target BP isn't reached with that initial low dose, you have a few options. You can gradually increase the dose of that first drug, stepping it up towards its maximum recommended or tolerated dose.
Option 1, increase dose.
Option 2, add a second antihypertensive agent from a different pharmacological class, choosing one that has complementary mechanisms of action.
Option 2, add a second drug.
Option 3, stop the first drug altogether if it was ineffective or causing side effects, and switch to a different medication from another class.
Option 3, switch drug class.
And it's important, generally, not to use more than one drug from the same pharmacological class concurrently. For example, don't use 2 different ACE inhibitors together. Guidelines often have tables, like Table 77.8, summarizing the main first-line drug classes and key considerations. Encourage patients to take their medication at the same time each day to build a routine. And home BP monitoring can be really helpful for tracking response between clinic visits.
Good point about home monitoring.
And it's crucial to set expectations. Many, perhaps most, patients will eventually need a combination of 2 or more different antihypertensive medications to actually reach and maintain their target blood pressure levels long term. Monotherapy doesn't always get you there.
Manage expectations about needing multiple meds.
Okay.
What are some common and generally recommended initial drug regimens for patients with straightforward, uncomplicated essential hypertension?
For uncomplicated essential hypertension meeting meds, several classes are considered good first-line choices. These mainly include ACE inhibitors, ACEIs, or angiotensin II, receptor blockers, ARBs, calcium channel blockers, CCBs, and thiazide, or thiazide-like diuretics. These can be used as monotherapy initially or sometimes in combination, as long as there are no specific contraindications for that patient.
ACEI, RRB, CCB, or thiazide, the big 3.
Pretty much. A traditional step care approach might look something like this. Step 1. Start with monotherapy. Maybe an ACEI or ARB, often preferred in younger patients 55, or those with diabetes, heart failure, CKD, or a CCB, or a low-dose thiazide diuretic, often a good choice in patients aged 65.
Okay, step 1, pick one.
Step 2. If the BP target isn't reached after maybe 3 months on monotherapy at a reasonable dose, add a second drug from a different class. Common effective combinations are ACEIRB plus CCB or ACAIRB plus thiazide. Sometimes ACEIRB plus beta blocker might be used, especially if there's a coexisting indication for the beta blocker.
Step 2, combine 2.
Step 3. If the target is still not reached on dual therapy, consider adding a third drug, again from a different class. A very common and effective triple therapy is ACEIRB plus CCB plus thiazide diuretic.
Step 3, triple therapy.
Step 4. If blood pressure still remains uncontrolled on optimal doses of 3 agents, including a diuretic, this is potentially refractory hypertension. At this point, you might consider adding spironolactone, an aldosterone antagonist, especially if potassium isn't high, or definitely seeking specialist advice. Guideline algorithms, like FI 77.6, often depict this stepwise approach visually.
That's a clear pathway. Are there any particularly good combinations, or conversely, combinations we should generally avoid?
Yes, absolutely. Some combinations work particularly well together, while others might be less effective or even increase risks. Useful synergistic combinations often include a thiazide diuretic combined with either an ACEI or an ARB, or a thiazide with a CCB, or a thiazide with a beta blocker, though perhaps less common now as initial therapy. Beta blockers combine well with diuretics or with dihydropyridine CCBs like amlodipine. ACE inhibitors or ARBs combine well with diuretics, beta blockers, or CCBs.
Okay, those are the good pairings. What about the less good or potentially problematic ones?
Combinations that are generally considered relatively ineffective for BP lowering include combining a diuretic with a non-dihydropyridine CCB, like varapamil or diltiazem. Also, combining a beta blocker and an ACE inhibitor isn't usually a first-line strategy just for BP, though it's common post-MI or in heart failure. Then there are undesirable combinations that should generally be avoided due to increased risk of side effects without added benefit. Definitely avoid using more than one drug from the same pharmacological class. Avoid combining a beta blocker with verapamil due to the additive risk of bradycardia and heart block.
Right, additive negative effects.
Avoid combining a potassium-sparing diuretic, like spironolactone or amiloride, with an ACE inhibitor or an ARB without careful monitoring due to the increased risk of hyperkalemia, high potassium. And generally avoid combining an ACE inhibitor with an ARB. Large trials showed this combination doesn't significantly improve outcomes compared to either alone, but does increase the risk of adverse effects like hyperkalemia and renal dysfunction.
ACEI plus ARB combo is generally out. Good to know. Could you briefly run through the main classes again, highlighting key characteristics or clinical pearls for each?
Sure. Let's quickly recap the main ones. Thiazide diuretics, like hydrochlorothiazide, chlorthalidone, indapamide. Good first-line choice, especially in older patients, or for isolated systolic hypertension. Need to watch electrolytes, particularly potassium, risk of hypokalemia. Can sometimes worsen gout or glucose control slightly. Less effective if eGFR is significantly low, say 30. Remember, NSAIDs can blunt their effect. Indapamide might be slightly more metabolically neutral.
Thiazides. Watch K plus gout eGFR.
Beta blockers, like metoprolol, atenolol, bisoprolol. Used less as first line now, unless there's a specific indication like angina, post-MI, or heart failure. Use cautiously in asthma COPD. Don't stop abruptly in patients with coronary disease. Can cause fatigue, bradycardia.
Beta blockers. Less first line now. Caution in lung disease.
Calcium channel blockers, CCBs. Two main types. Dihydropyridines like amlodipine, felodipine, nifedipine are potent vasodilators. Common side effect is ankle edema. Can be used with beta blockers. Non-dihydropyridines, verapamil, diltiazem, also slow heart rate, so avoid with beta blockers and use cautiously in heart failure. Verapamil can cause constipation.
CCBs. Dihydros. Edema. Non-dihydros. Rate slowing.
ACE inhibitors, ACEI supprols like perindoprol, ramipril, lisinopril. Excellent first-line agents, especially with heart failure, diabetes, kidney protection, post-MI. Main side effect is that dry cough, up to 15%. Rare but serious risk of angioedema. Monitor renal function and potassium when starting. Remember, the HOPE trial showed significant CV benefits with ramipril.
ACEIs. Cough. Angioedema risk. Good for diabetes, HF post-MI.
Angiotensin II are receptor blockers. ARBs, the sartans like candesartan, irbesartan, telmisartan. Similar effects and benefits to ACEIs, but block angiotensin II action differently. Much lower risk of cough than ACEIs. Similar risk of angioedema, though maybe slightly lower. Also need to monitor renal function and potassium, often used if patient can't tolerate ACEI cough.
ARBs. Like ACEIs, but less cough.
Alpha blockers, like prazosin, terazosin, not generally first line for hypertension alone due to the risk of postural hypotension, first dose phenomena, and studies suggesting poorer outcomes than other classes. LHAT trial. Might have a role in men with BPH symptoms.
Alpha blockers. Not first line. Postural hypotension risk.
Others like direct vasodilators, hydralazine monoxidil or central agents, methyldopa, clonidine, are usually reserved for resistant hypertension or specific situations like pregnancy, methyldopa. Spironolactone, an aldosterone antagonist, is increasingly used as a fourth-line agent in resistant hypertension.
Okay, that's a great overview of the main drug classes. What about hypertensive emergencies? What defines them, and what's our role as GPs?
A hypertensive emergency is when severely elevated BP is causing acute, life-threatening target organ damage. This could be hypertensive encephalopathy, severe headache, confusion, seizures, acute stroke, acute heart failure with pulmonary edema, acute coronary syndrome, aortic dissection, or eclampsia preeclampsia in pregnancy.
Serious, immediate threat.
Absolutely. Patients need immediate hospitalization, usually in an ICU or high-dependency setting, for urgent monitoring and intravenous treatment. Our role as GPs is prompt recognition of the potential emergency based on symptoms and BP level, and arranging immediate transfer to hospital via emergency services. While definitive treatment happens in hospital, the general principle, except in specific cases like aortic dissection or maybe acute stroke needing thrombolysis, is not to lower the BP too rapidly. Overly aggressive lowering can actually cause harm, like cerebral or myocardial ischemia.
Gradual lowering is key.
Generally, yes. The typical initial goal in hospital is often to reduce the mean arterial pressure by no more than 25% within the first hour or two, then gradually towards a safer level like 160-100 over the next 2 to 6 hours. Specific 5E drugs like labetalol, nicardipine, sodium nitroprusside are used. Magnesium sulfate is specific for eclampsia.
Okay, recognize and refer urgently. What about the opposite end, refractory hypertension? Patients not responding to multiple drugs?
Right, refractory hypertension. That's when BP stays above target, despite being on optimal doses of 3 or more drugs, including a diuretic.
Oh.
The first step is always a thorough review. Systematically check. 1. Is adherence an issue? Are they actually taking the meds as prescribed? 2. Could there be an underlying secondary cause we missed? Reevaluate for renal artery stenosis, aldosteronism, sleep apnea, etc. 3. Are other substances interfering? Review all medications again, NSAIDs, alcohol intake, recreational drugs. 4. Is the measurement accurate? Could be white coat effect. Consider ABPM or more rigorous home monitoring. Is the cuff size correct? 5. Is the volume status optimal? Are they fluid overloaded? Is the diuretic dose adequate for their renal function? 6. Is obstructive sleep apnea present and untreated?
Systematic review is crucial.
Absolutely. If you've addressed all these factors and the BP is still not controlled, referral to a hypertension specialist or clinic is definitely warranted for further workup and management, potentially including adding drugs like spironolactone or other less commonly used agents.
Okay. We also need to touch on specific populations. What about hypertension in children and adolescents?
Yes, important area. BP isn't measured as routinely in kids, but we should be vigilant, especially in those with risk factors. Family history, obesity, kidney disease, diabetes, certain congenital heart conditions. Secondary causes are proportionally more common in children than adults, although essential hypertension is still the most frequent cause overall, especially in adolescents. Kidney problems, parenchymal disease, renal artery stenosis are common secondary causes.
Look harder for secondary causes in kids.
Definitely. Symptoms like visual changes, recurrent headaches, seizures, or failure to thrive might be clues. Also consider medications like corticosteroids or OCPs in adolescents. There are age, sex, and height-specific BP charts for defining hypertension in children, often used in percentiles. Accurate cuff size is absolutely critical. Using too large or too small a cuff will give very wrong readings. Electronic devices are often used in younger children.
Like size again.
Always. The diagnostic evaluation follows similar principles to adults. History, exam, basic labs, checking for secondary causes. Drug treatment in children is usually managed by, or in consultation with, a pediatric specialist, nephrologist, or cardiologist. Lifestyle is key, especially weight management if obese. If drugs are needed, ACE inhibitors or CCBs are often preferred first-line options. But remember, ACI-ARBs are contraindicated in pregnancy, so avoid in post-pubertal females who could become pregnant.
Specialist input usually needed for pediatric drug therapy. Got it. And finally, the elderly, a huge group with hypotension. Key management points.
Yes, very prevalent. BP tends to rise with age, and isolated systolic hypertension is particularly common due to arterial stiffening. Key guidelines. ISH is definitely worth treating in the elderly. It reduces stroke and heart failure risk significantly. Older patients can still respond well to lifestyle changes, especially sodium restriction. When starting drugs, start low, go slow. Begin with maybe half the usual adult dose and titrate upwards cautiously over weeks or months.
Start low, go slow. Mantra for the elderly.
Absolutely. For older patients, say over 75 or 80, who are otherwise reasonably healthy, treatment goals might be similar to younger patients. But you always need to weigh the benefits against the risks more carefully, especially the risk of falls due to postural hypotension or side effects. Reduce BP gradually. Drug reactions and interactions are more common, so review all their medications carefully. Watch for interactions with NSAIDs, Parkinson's drugs, etc.
Polypharmacy issues.
Big time. For specific drug choices, low-dose thiazide diuretics, especially indapamide, are often excellent first-line agents. Monitor electrolytes, K+, 80, and A+, closely after starting. Be mindful they can worsen bladder issues like incontinence or BPH symptoms. ACE inhibitors or ARBs are good second-line options, especially if there's coexisting heart failure or CKD. Again, monitor renal function and potassium. Other effective drugs include CCBs, especially dihydropyridines, and low-dose beta blockers, if there's an indication like angina.
Okay, tailored approach, cautious dosing. What about special management problems, like choosing drugs with coexisting conditions?
Yes, guidelines often have tables, like Table 77.9, summarizing preferred or contraindicated drug classes based on comorbidities. For example, heart failure, ACEIRB, beta blockers, specific ones, diuretics, aldosterone antagonists are generally preferred. Avoid non-dihydropyridine CCBs, post-MI. Beta blockers, ACEIRB are key. Diabetes, ACEIRB are often first line due to kidney protection. Thiazides and beta blockers can be used but monitor glucosolipids. CKD, ACIRB are usually preferred, especially if proteinuria present. Dose adjustments often needed. Loop diuretics may be needed instead of thiazides if GFR is low. Asthma COPD. Avoid non-selective beta blockers. Cardioselective ones might be used cautiously. ACEI cough can be problematic. CCBs or ARBs are often good choices. Gout. Avoid thiazides if possible or use with caution. Losartan, an ARB, has a mild uricosuric effect, which might be beneficial.
Very helpful having those comorbidity considerations in mind. What about step-down treatment? Can people ever come off medication?
That's a common question. Drug treatment for essential hypertension doesn't necessarily have to be lifelong for everyone, particularly if it was mild hypertension initiated, perhaps borderline, and they've made significant sustained lifestyle changes. If a patient's BP has been consistently well controlled on minimal medication for a long period, months to years, and their overall CV risk profile has improved, it might be reasonable to cautiously consider reducing the dosage or the number of drugs. This is sometimes called deprescribing.
Deprescribing.
Yes. The principle is, a drug should only be continued if the benefits still clearly justify its ongoing use. However, just stopping medication suddenly, drug holiday, can be hazardous, with potential for rebound hypertension.
Right.
Any attempted step-down therapy must be done very gradually with careful monitoring of BP, ideally including home monitoring, and ongoing emphasis on lifestyle measures. It's often best attempted in lower-risk patients who are highly motivated.
Careful monitoring is key if attempting step-down. Finally, when should we definitely consider referring a patient with hypertension to a specialist?
Referral is appropriate in several situations. Refractory hypertension BP not controlled despite W3 drugs. Suspected significant white coat hypertension needing confirmation, for example with ABPM if not easily accessible. Severe hypertension, e.g. diastolic consistently 115 millirhg, that's difficult to manage in primary care. Any hypertensive emergency, immediate referral to hospital. Evidence of ongoing target organ damage, for example worsening kidney function LVH, despite treatment. Significant kidney impairment, e.g. EGFR 30 mmol, complicating management. Suspicion of a treatable secondary cause that requires specialist investigation or management, e.g. renal artery stenosis, pheochromocytoma, primary aldosteronism. Hypertension in pregnancy always requires specialist obstetric or physician input, and hypertension in children usually warrants specialist consultation.
That's a clear list of referral triggers. This has been an incredibly thorough and I think really practical deep dive into hypertension. Before we wrap up, could you just summarize the absolute key takeaways for our listeners, especially those GPs and registrars?
Certainly. I think the main points are, 1, hypertension is a massive issue in our community, a major driver of cardiovascular disease. Don't underestimate it. 2, accurate BP measurement is the foundation. Technique matters, cuff size matters, repeat measurements matter. Consider out-of-office readings when needed. 3, risk stratification is essential. Don't just treat the number. Assess the whole patient, their absolute CV risk, other risk factors, target organ damage. Use risk calculators. 4, management is twofold. Lifestyle modification is vital for everyone. Pharmacological therapy should be guided by risk, BP level, comorbidities, and chosen carefully, often requiring combination therapy. 5, patient education, adherence support, regular monitoring, and keeping an eye out for secondary causes in special populations, kids, elderly, pregnancy, are all crucial for long-term success.
Fantastic summary. And building on that, here's a final thought provoker for everyone listening. Given this increasing prevalence of hypertension and the pressures on primary care, what proactive or maybe even innovative strategies can we as GPs implement in our practices and communities to really boost early detection, promote primary prevention effectively, and start tackling some of those socioeconomic and ethnic disparities we know exist in hypertension control?
That's a really important question for the future of primary care, isn't it? Lots to think about there.
Indeed. We really encourage you to check out the show notes. We'll put links there to relevant Australian guidelines and some of those risk assessment tools we mentioned. Please share this deep dive with your colleagues, especially GP registrars studying for exams. And do send us your questions or topics you'd like us to cover in future episodes.
Yes, we always appreciate hearing from you.
Thanks so much for joining us for this detailed discussion on Beyond the Stethoscope, the podcast for general practitioners. We look forward to having you with us again next time.